Fabulous. Down the row.
That's great. Thank you. Good morning. I'm Bill Jacobs. Thanks for having me here. It's an honor to be in a room with all these really smart people. It's one of the reasons I came back to UF. That and Dr. Gold, you can put the clicker away, but you can just use that usual Jedi mind trick that you do to control me. That works pretty well, I think, over the last 16 years. I'm a Georgia boy, and I'm a little slow country doctor, and so I don't know how I can do anything in 10 minutes. It takes me 10 minutes to say hello. And Mark gave me this title that I'm going to read to you that says, UF Pain Medicine Evaluation, Triage, Treatment, and Prevention of Iatrogenic Addictions. Well, I could do each one of those in about an hour and a half. So I changed the title a little bit just to recognition and response of the complex problems. And I'm really glad to be here because I think pain is an integral part of our whole addiction problem in this country right now. As we all know, the prescription opiate epidemic has now fueled another surge in the heroin epidemic, and it's being driven by pain. Acute pain has not really been the problem. We've always done a pretty good job of treating that. It's chronic pain that's been the issue. When I trained prior to 1995, nobody with chronic pain got opiates on a daily basis. The only people that got opiates on a daily basis were patients who had terminal cancer or AIDS, and back at that point, AIDS was terminal. So, we had a complete paradigm shift over the last 20 years, and the pendulum has swung a great deal in one direction, such that now, I'm working with a group in Jacksonville looking at overdose deaths, and we found dentists who are prescribing 120 30 milligram oxycodones for a dental extraction. So we also have a chronic pain syndrome, which is really an end of the spectrum of chronic pain. And it's more than just chronic pain. It's a whole constellation of behaviors that are related to the persistent pain and represent a significant role, life disruption. Now, there's Dr. Smith's a definition of addiction, and as Dr. DuPont said, that last line down there at the bottom, relapses or failed attempts to cut down, certainly is part of the disease, but I don't think it has to be part of the disease. We recognize it could be, and we treat it as I think we've talked about earlier today, and we can certainly make that a much less important part of this and leave it at the bottom where hopefully it belongs and will stay. Complex pain is chronic pain is a really complex problem. It is another biopsychosocial disorder. There's no one-to-one relationship between organic pathology and pain intensity. For years we thought osteoarthritis of the knee was a classic nociceptive pain disorder. But I can tell you, over 30 years of looking at knee x-rays, I can't look at a knee x-ray and tell you how much the patient hurts. I look at knee x-rays that look relatively normal, mild osteoarthritis, and they have tremendous amounts of pain and can barely walk. And I look at other knee x-rays that there's almost no joint there, and those patients come in and say, yeah, it bothers me a little bit when I go up and down the steps, but it's not too bad. Don't worry about that. Let's talk about my other problems. So even the things that we thought were straightforward, peripheral, nociceptive type pain disorders are not. The brain is involved in all this. I tell my patients all the time, if you didn't have a brain, it wouldn't hurt. If I chopped off your head, you wouldn't care anymore. And their chronic pain disorder is really shaped by all these multiple factors, biomedical, behavioral, the context secondary gain factors, the responses by their significant others. I mean, Bob DuPont and I were talking earlier. If for some people, getting the chance to lay on the sofa and take a pain medicine every day and be catered to by family members is a pretty attractive option. And why would they want to get up? I mean, people in this room don't think that way because they're motivated go-getters, but there are a lot of people in our society that are not wired that way. There's a huge psychosocial component to it. And even as with treating addiction, the patient's and the provider's beliefs, expectations, and moods play a big role in all this. Now, in the past, the usual evaluation for a patient with chronic pain, and this isn't the way we do it, but I just want to show it to you as the way I was initially trained. We had this incorrect assumption and hope by both the patients and the providers that we'd find this underlying, pathology, this magical pain generator that was both necessary and sufficient to cause the symptoms and the behaviors that the patient was having. And we'd go through these attempts to identify the pain generator with our history and physical and appropriate testing. And unfortunately, a lot of the times we wouldn't find that magic pain generator that was responsible for all of that pathology that we were seeing. And so providers would then have a response where we would say, well, this must be a psychological condition. And we'd immediately knee-jerk a psychiatric or a psychological evaluation. So there was this dichotomous view or duality where it was an either-or, it was a somatic or a psychogenic problem. Had to be one or the other. And really, this isn't an either-or. The chronic pain issue is a both issue. And we have to treat both parts of the problem if we're going to have success in treating chronic pain. So, as I said earlier, it affects more than just the individual. There's so many factors that influence the symptoms and the functional limitations. And so part of our comprehensive assessment is we do a search for the pain generator, and sometimes we find one that's significantly contributing, and we treat that. But we also have to look at the psychosocial, the behavioral situation, the emotional state, the comorbid depression, anxiety, the frustration that goes with suffering chronic pain, and the anger that goes with it. A lot of my patients come in angry. Most of the patients that I see have been to at least half a dozen other doctors before they get to me, and they're frustrated that nobody's been able to find that magic problem and wave that magic wand for them and take their pain away. So they're very frustrated and angry. And they're supported usually. They show up, usually they don't show up alone. They show up with a significant other who's got a lot of codependency and invested in the situation. And so, we do a real strong evaluation for both the presence and the potential for coexisting addiction before we ever start treatment. And our treatment philosophy is to treat the whole patient and all people significantly involved in their lives. And maybe that sounds a little like addiction treatment. I think it is and should be. We coordinate care with multiple specialists. We continually monitor, reassess, adjust the care, and then repeat the process. Because most of these people, I tell them from the get-go, I'm not going to make you pain-free. I have a lot of patients that come in that are 72 years old, they have horrible necks, have had 6 or 7 back surgeries. I tell them, I can't give you that back you had when you were 20. If I can take away some of your pain and more importantly, allow you to do more of the things that you want and need to do on a regular basis, then we have worked as a team together to be successful. And the other thing I'd like to say, and this is a huge topic and we could spend a lot of time on, that just opiates is not only not the answer, it's fueling the problem. And we're finding more and more data that says that chronic opiate therapy for these pain problems is really just making things worse. I've seen it in my practice, in my private practice. There's more data coming out to support that. I think today, if we took oxycodone to the FDA and tried to get it approved as a pain medicine for osteoarthritic knee pain, we couldn't do it. It wouldn't meet safety and efficacy. So I heard a click. I thought you were going to zap me. You know. And the other thing I'd just like to mention that we're doing is we're using very innovative state-of-the-art interventional procedures. We're pioneering cooled radiofrequency treatments. We're doing them in the neck. I've just done the first in North Florida in the knee to denervate, basically temporarily denervate the knee, even in patients who have had total knee replacements, that injections intra-articular are not going to do any good anymore. And we're going to be the first in probably next month to be able to do a similar type procedure on the hip. So I hope that you'll allow us to intermix the problems that are associated with chronic pain and evaluation and treatment of chronic pain with this very ambitious and very, very exciting addiction project. Thanks. Oh, and I have to put this one up here and say thank you to my mentor of 16 years. You know, I couldn't have had a better opportunity in my life than to have worked for Dr. Gold for 16 years. Thank you.